As I was saying, today we have, as I was saying, today we have here Professor Eleanor Brooks. Professor Brooks is lecturer in health policy at the Global Health Policy Unit at the University of Edinburgh. And she's one of the leading specialists in European health policy. In general, her research focuses on the political determinants of health, and especially, as I was saying, on the determinants of health policy in the EU. Like she research focuses a little bit on the governance mechanisms of health in the EU, on the policy areas in which the EU is active in the kind of actors involved in EU health policy. She's also the scientific advisor to European Public Health Alliance, and she is currently the principal investigator of the project Better Regulation for Better Health projects, for better health. And in the recent years, she has been publishing a lot on this project that she will be talking about today, on the European Health Union. So, Eleanor, the floor is yours. And I think in 5 minutes, you will be able to see us.
Okay, super. Professor, can I just check that you can hear me okay, given that I can't see you for any waving? The sound is okay?
La sentiu bé? Yes.
Great. Okay. All right. Well, thank you so much for the invitation, and good morning, everybody. It's a pleasure to be here. As was mentioned, my name's Eleanor Brooks. I'm a lecturer in health policy at the University of Edinburgh. My background is actually very similar to, I imagine, many of the students in the room. So I studied European studies as part of a politics degree for my undergraduate and my master's. And then my PhD, I turned to health policy specifically. And now I'm based at the University of Edinburgh in the Global Health Policy Unit, which is a group of people who do health policy, critical health policy issues from all sorts of different social scientific backgrounds. So I'm moving slightly towards a more interdisciplinary setting now, but I started roughly where most of you are today, I think. So I'm really pleased to join you and to talk about the European Health Union this morning. I'll just run through what we're hoping to cover. So I'll talk a little bit about health as a policy area and start from the very beginning of that for people who maybe haven't learned anything about health policy before. And I'll talk a bit about the role of policy in improving people's health. I'll then talk about the EU's health policy and just give you a framework for what we think about the EU's health policy as including and containing. I'll speak a little bit about COVID-19 because it's difficult not to, and how the Health Union sort of came into existence and was created. And then I want to touch on this idea of a health union for sanitary crisis, the idea that the health union is only for sanitary crisis and for health security, and whether there's any potential for it to be something bigger than that. And along the way, I'll try to speak to some of the integration debates that you'll be covering on your courses, so that you can link all of these things together. So to start off, this diagram will probably be unfamiliar to most of you unless there happen to be any public health medics in the room. This is a diagram that models what we call the social determinants of health. So this is a diagram from the medical discipline, from the public health discipline. And the idea of it is to try and convey how healthcare services, which you see in the green arc here on the right-hand side, healthcare services are just one small part of all of the things that affect our health as individuals, but also as populations. And the diagram was created, it was designed with the objective of trying to help policymakers understand that if you wanted to improve the health of a population, you needed to target things beyond just the health system. So simply ploughing money into a health system or reforming a health system was not going to be enough to improve the health of the population. So you see that it's designed in a kind of rainbow shape. We call it the rainbow model sometimes. And the idea is that the things closest to the center are the things nearest to you that affect your health. And then as we get wider and wider out of the rainbow, we see factors that are further away from the individual, maybe not so much in the individual's control, but that still affect their health very significantly. So, okay, at the very centre, you have age, sex, and constitutional factors, so the things about you as an individual. Then one step out from that, you have what we call lifestyle factors. So this is your decision to smoke or to drink lots of alcohol or to not exercise or to eat foods that are bad for us. These are all lifestyle factors, decisions that we make. And you'll notice immediately perhaps that quite a lot of health policy, government policy, is targeted towards these lifestyle factors, to encouraging us to exercise more or not to smoke or to drink less or something like this, because the common wisdom over many decades, I suppose, has been that this is how to change people's health. The purpose of the diagram and much of public health work is to demonstrate that actually this initial rainbow of lifestyle factors is not the most important, and it certainly isn't enough on its own to change these factors. So immediately outside of the lifestyle factors, you have the social and community networks. This is the idea that the community in which you live, where you are based, your social networks, who you have interaction with, the extent to which you have interaction at all. Loneliness is increasingly recognised as a public health problem in many countries. So whether people are embedded in a supportive social and community network, that's an important factor determining health. The green row is perhaps the one that we think of most directly from a policy sense. So these are obviously policy areas. Housing is a policy area, unemployment is a policy area, and we call these the living and working conditions that determine health. So all around the edge, we can imagine how agriculture and food production affects health, how our education is linked to our health, the way where we work, whether the work environment is safe or not will affect our health. So that's the policy facing sort of green area of the rainbow. And then on the very outside of the rainbow, we have what we call general socioeconomic, cultural and environmental conditions. So this is talking much more widely about the economy of the country that you live in, the culture in which you live. Environmental conditions means sort of both the environment, the physical environment in terms of climate change and things, but also just the local environment in which you live. These are much further away from the control of the individual. In many ways, the influence that an individual has on these sorts of factors is limited to elections, almost to electing people that can do something about these problems. So they are far away from the control of any one person, but they have a very significant impact upon population health. So the purpose of the diagram, and the reason I introduced it at the beginning of this lecture, is to show how wide the range of policies and concerns that affect health is, because that has a knock-on implication for the EU's role. The EU, yes, it might have a small role in healthcare services and in advising or offering some best practice about how to deliver healthcare services, but actually we need to look to the EU's role in all of these other areas in order to properly understand what its health policy is and how it influences health. So let's take a step then into the EU's health powers themselves. So this is a text-heavy slide, but I've highlighted the bits that are particularly pertinent for our purposes. So this is Article 168 of the Treaty on the Functioning of the European Union, and this is the article that's specifically about public health and that gives the EU its health powers. So you can see in the very first part of the article that the EU is committed to providing or ensuring a high level of human health protection, which sounds pretty good, right? That's the overarching objective of what it is that the EU is trying to achieve in all of its policy activities. But if we look to some of the following highlighted words and phrases, so complement and encourage cooperation and lend support, and a little further down in Article 5, you can see incentive measures. These are all words that express to some extent the limitations of the EU's competence in health. So health remains primarily a national responsibility, and the EU's competence is a shared one. It's a supporting competence. It is supposed to support the member states in their health policy areas. This is not a strong competence like we see in the area of the internal market, for example, where the EU has exclusive competence to make regulations and to dictate what member states should do. Health is very different to that. In point 4, we see a slight derogation to that. So there are some very specific areas where the member states have agreed that the ordinary legislative procedure can be used, and the EU has some stronger powers there. And you'll see in that list of ABC that these include what we call the substances of human origin. So that means human organs, blood, tissues, cells. In this area, the EU has strong powers to set quality and safety standards. Similarly, in certain areas of veterinary and plant health, and that has a lot to do with the spread of diseases, the EU has some strong powers. And also in the case of medicinal products and medical devices, so that means medicines, pharmaceutical drugs, and medical devices that are used in healthcare. In those three areas, the member states decided when they drafted this part of the treaty that the EU should indeed have stronger powers to be able to regulate. But notice that these are all about quality and safety. It's less about trying to promote population health more widely. It's very specifically indicated as being about quality and safety. Perhaps the most important point of Article 168 is point 7, in fact. And you can see that this says very explicitly that the European Union will respect the responsibilities of the member states when it comes to health. And the part of health that has been identified specifically is the organisation and delivery of health services and medical care. So the way to understand the EU's role in health is to think of health as having two different aspects, if you like. So one is public health, and public health is about the health of all of us as a group. So everybody that's sitting in the classroom just now, everybody in your community, everybody in your hall of residence. It's about health on a population level. It's not concerned with the individual. The other part of health is concerned with the individual, and we usually refer to that as health care, because it's about the care you receive as a single individual person. And that's much more about how services are procured and delivered, how hospitals are run, how they're financed, how that whole system of medical care is delivered to an individual. It's about your access to your doctor, essentially. Now, at the EU level, Article 168, most of what's included here up until point 7 is about public health. It's about the health of everybody as a population. In many ways, the European population, although we'll touch on how it has a more global aspect a little bit later. What the EU is not allowed to be involved in, and what is indicated in point 7, is health care, is your relationship to your doctor, the delivery of health services within a member state. That is the responsibility of national governments. The reason that point 7 is so important is because it's very rare. There are very few policy fields within the treaties that have an article that says explicitly what the EU will not do. Most of the treaties list in the particular policy sectors and policy areas what the EU will do. So the EU has the power to do this and it will try to achieve that. Very few of them feel the need at the end of the article to state what the EU will not do and will not be allowed to have a role in. And that's a really important indication of how sensitive health policy is at the national level and how keen member states were to make sure that the EU doesn't overstep the mark and is not involved in this area any more than it needs to be. So this is a useful place for us to start our consideration of how member states feel about the EU's role in health and what that means for the EU's competences in this area. The cartoon you can see on the screen comes from a book that some of you in preparation for the class maybe might have seen. So the book is called Everything You Always Wanted to Know About European Health Policy But Were Afraid to Ask. And it's published by the WHO Observatory on European Health Systems and Policies, which is based in Brussels. I've been lucky enough to be involved in the more recent edition of this, but this cartoon is from the very second edition, in fact, the 2019 edition. And what it symbolises is exactly what I've just been talking about in terms of the treaties and the things that influence health. So the cartoon is meant to depict the idea that what member states have built with Article 168 is this gate. And it is a gate that's supposed to stop the European Union from being involved in health policies. What they have not considered in building that gate is that most of the things that affect health, as we saw in the rainbow diagram, actually have very little to do with healthcare. They're not what we would consider health policies. They are things like agriculture or the internal market or competition regimes or trade or even the European semester in the EU's fiscal governance framework. So the cartoon is meant to put across this idea that I've been trying to explain, that the member states have built a gate designed to keep the EU out of health in all except for a couple of small areas that they have specifically identified. But the reality of integration in health is that because of all of these other avenues by which the EU has an influence over our health, it actually plays a really central role anyway despite the government's efforts to, the member states' efforts to draft an article that kept the EU out. A little later on, I'll show you an updated version of this diagram that helps to understand a little bit what's happened in the post-COVID period. So having a look at what it is that the EU does in health and what I tend to call the EU's non-health policy. So this is a diagram that I have updated on the basis of a paper by Clemens and colleagues from 2017. And you can find the reference to the original diagram if you want to compare. But so the centre of the circle, the dark blue areas, represent the activities of DG Santé, so the European Commission's Department for Health, as it were. And you can see that those are divided into the two areas of health at the top that I mentioned. So public health, which is these areas like cancer and other non-communicable diseases, health security, so that relates to infectious diseases, communicable diseases, and pandemics indeed. EU for Health is the EU's health programme that I'll talk about in a few moments, and it's responsible also for coordinating various networks and gathering statistics and procuring and curating health information, as it were. On the health system side, which is a member state responsibility, but the EU has some either identified roles or areas where it uses soft law to support member states, and that includes medicines. There's a lot of work on the modernisation of health systems, the use of digital technologies and big data, and also health technology assessment, which is a process that is used to evaluate new health technologies and their value and their worth for the health system. But so those are the sort of how would you say, the core areas of health that DG Santé is involved in. The other half of DG Santé's responsibility is food safety and sustainability. I'm not going to talk too much about that today because it's quite separate from public health. They contribute to the same goal, and food safety is very important for public health, but the areas of activity are quite different from health. So I'm going to focus on the top half of the dark blue circle for today. Perhaps the more interesting part of the diagram is the light blue circle around the edge. And here we've listed all of, or almost all of, the other departments within the EU, that within the European Commission, that have a role in health, or whether intentionally, which is very rarely the case, or accidentally, indirectly, because of what they do. And again, you can think back to the rainbow model about why it might be that all of these things affect health. But I'm not going to go through every single one, but we can pick a few examples for illustrative purposes. So DG Klima, for instance, in the bottom right of the circle, that's the Directorate General responsible for climate action, climate change, and the health of the climate are closely interlinked, obviously, with public health and with all of our health. On the exact opposite side, DG Trade, the trade agreements that we negotiate, the kinds of goods that we allow in and out of the European market, whether that's unhealthy goods like highly processed foods, or whether that's healthy goods, whether that's trade in pharmaceuticals, in fresh fruit and vegetables, whatever it is. Trade agreements play a huge role in our health and in patterns of disease across the world. In fact, globally, research has shown the importance of trade agreements. It's similarly true for the European Union. In the top right, what do we have here? So DG Research, RTD, obviously funds an awful lot of research that's important to our health, but also important to all of the other areas in the rainbow diagram that help us to understand how those things affect our health. On the opposite side of that, agriculture, we've mentioned. DG ECHO is the directorate responsible for humanitarian aid and the rescue programme, which I'll talk about in a few minutes. And again, here we can see how this might play a part in the EU's role in health beyond its own borders, or indeed within its own borders in the case of an emergency. So there are a number of examples there. Some of them will be more or less obvious to you, but each of those are areas that have an effect on health in some way. But in none of them, really, with the exception maybe of DG HERA, is health the objective of the directorate. So the directorate's mandate is not necessarily to improve health, it's usually to do something else. But the activities that they engage in and the policies that they adopt inevitably affect health because of what we know from the rainbow model. So this is just to give a sense of the breadth of what we might understand health policy to include, and also the idea that a lot of it is not health policy at all, it's policy in other areas. What that means for the Commission, and particularly those working in DG Santé, is that constantly the challenge is to to include a health perspective and the understandings from a health side in other policy areas. And really practically that means being involved in the conversations that are happening in departments other than the Department for Health, right? Making sure people who have a background in health are involved in those policy discussions so that they understand the impact on health they have, even though they may not be seeking to have an impact on health at all. Excuse me. Okay, so turning to the 4 faces of EU health policy, when we think about what EU health policy is, given how big it could be, as we've seen in that last diagram, we usually think of it as having 4 faces, and this is a useful way for us to conceptualize what it is that the EU does. So the first face is what we would call the public health face, and that's about policies which are explicitly designed to improve health. So this is policies where the aim is very explicitly, in the way they're written, to improve health rather than to achieve something else. So normally those would be based on Article 168, although at the bottom of the box you see I've put environment, health and safety, consumer protection. Some of those are separate legal bases, so they excuse me, they exist in other parts of the treaty. They maybe have their own legal basis, their own article, and oftentimes they will have within that article a separate commitment to public health that allows them to protect consumers but also to achieve public health, for example, at the same time. So there are some other legal bases that would fall under the first face that are slightly separate but still have this explicit commitment to health. So in terms of hard powers, we can think about the examples that we saw in the treaty article, so in the area of pharmaceuticals, of medicines and pharmaceutical drugs. Blood, tissue, cells, human organs is another example, and there's quite extensive legislation on the substances of human origin. And that covers things like how to safely transport organs from one place to another, how they should be stored. It's making sure there is a harmonised set of health and safety requirements, quality and safety requirements for organs across all member states, because that means we can have what some people might refer to as a market for organs. Organs are obviously a very sensitive area and a very important area, so some people would struggle a bit with that idea of a market because that sounds a little commercial, and that's not quite what it is. But we have a system across Europe for the exchange of organs and the pooling of organs, if you like, to make sure they can reach people who need them. And what that requires is a set of regulations about how they are acquired and then how they're safely stored and transported and recorded. So that's an example of one of the areas where the EU has these really hard powers. A good example of supportive action is the joint vaccine procurement. So you may have heard about this during the pandemic, the system that was put in place and then used to procure vaccines collectively across the EU. That's what we would call a supportive action. The EU doesn't have an exclusive mandate to do that. That was the Commission acting to support the member states rather than with exclusive competence. Programme activity, what we mean by this is all of the work that DG Santé and occasionally other parts of the Commission do that supports health and is explicitly aimed at improving health, but does not have an exclusive mandate, a hard power mandate, if you like, under the treaties. So this is all what we would call soft law. So the EU for Health programme is, as it sounds, it's the EU's health programme. It's a 5-year programme that the EU uses to sort of structure its activities and what it's trying to achieve. So under that programme, we have a whole raft of activity to target cancer, for instance. Some of that is research activity, some of it's about building networks between hospitals and different health professionals, some of it's about developing something called the European Code Against Cancer, which is a set of guidelines about how to prevent cancer. That's just one narrow example, but EU for Health is a series of, I think there are 10 objectives and numerous lines of activity and areas of activity underneath. But all of it is soft law, all of it is voluntary. It doesn't compel member states to do anything because there isn't a legal basis for that. The other important programme activity to be aware of is something called the State of Health in the EU cycle. So this is an initiative that runs on a 2-yearly cycle with the WHO, where the EU works together with partners to assess the state of health in the EU and then sort of propose recommended actions. It's very much based on data and measurement and indicators and getting some sense of health within countries and between countries. It's very much an information collecting and presenting exercise with some recommendations off the back of that, but it's not it's not an active intervention, if you like, in that sense, and that's because it's non-binding and it's not based on a formal mandate. In terms of the second phase of EU health policy, so this is the phase that we would call the market phase, the internal market phase of health policy. So this is all of the areas where the EU uses its very strong mandate to regulate the internal market that have an impact upon health. And we can think of that in terms of goods, people, services, and capital, the four freedoms that are associated with the internal market. Health goods are perhaps obvious, so we have these powers in pharmaceuticals and medical devices, but that also applies, the health goods dimension also applies to things like tobacco and alcohol, and goods that are regulated in terms of how they're produced and manufactured and sold and advertised, really crucially. All of those rules about where tobacco can and can't be advertised, for instance, they're not explicitly about health. That might be a secondary objective or a joint objective in some cases, but the main legal basis on which those regulations are adopted is an internal market legal basis. So it's a non-health policy that has a huge impact upon health. When we think about health people, if you like, we can think about that in two senses. So one is health professionals, nurses and doctors and dentists and whoever else. Their movement throughout the EU is facilitated by a set of regulations about how we recognise professional qualifications. So the idea that if you're qualified as a doctor in one state, that has to be recognised in another state. Again, those rules were not adopted with health professionals in mind. They are horizontal rules that apply to a whole range of professions and sectors, but they determine the distribution of and facilitate the movement of health professionals around Europe. An important implication of those is something called brain drain, which you may have heard in other settings, this idea that we get highly qualified health professionals from some parts of Europe moving to other parts of Europe where the pay or the conditions are better, and that's a serious problem that the EU works on a lot, but mostly in a soft law capacity because there isn't a hard law mandate to work on that. So there are lots of action plans for addressing the migration of the health workforce more fairly and helping to compensate countries that are losing doctors and nurses. But all of that is done on a soft law basis because the mandate under the first phase doesn't cover it. And the second way of thinking about people is patients. Is you, is me, is everybody else. People moving around to receive their healthcare in other countries. Assuming you're all EU citizens, I'm regrettably not anymore, but for those who are EU citizens, you have the right to receive your healthcare in any other member state, and your member state has to reimburse that. There are a few conditions under which you can do that, but they're fairly minor. It's not a policy that's used a lot. It's not a popular policy because people prefer to receive their healthcare in their home country. They prefer not to address the language barrier and the change in sort of healthcare culture, if you like, that's involved in going to another country. But you, as an EU citizen, you each have that right. And that was a fairly crucial piece of legislation that, again, was only 50% based on the health legal basis. The other 50% was a market basis. And health services and capital, I'm not going to talk about in too much detail, but this is the idea that you can provide health services in any country. If you're a company that provides, I don't know, cancer care or something, you have the right to provide that service in another country without any additional barriers than you would in your home country. And indeed, investment in health companies, I don't know, health insurance companies, whatever they might be, that has freedom of movement as well, in the same way that capital has freedom of movement across the internal market. So thinking about the four freedoms and the four aspects or dynamics of the internal market can be a useful way of just breaking down what we mean by this second phase of health policy and the internal market aspects. To the third phase of health policy. Now here we start to get really quite far away from what we might think of as health at all. Now we're really into a policy area that we would be forgiven thinking probably had no connection to health in the slightest. So the third phase is what we call the fiscal governance phase. And this is all about the policies that followed the economic and the financial crisis in sort of 2008 to 2010, all of those policies and how that were adopted in the aftermath and how those affect health. So this is all based on a completely different article of the treaties, Article 121, along with a bunch of others that set out how the EU interacts with and engages with the economic policy of its member states. Now, I mentioned the European semester when I was showing the cartoon from the WHO volume. The European semester is an annual cycle where the EU engages with governments as they design their budgets and their spending capacity and their plans for sort of fiscal reform. And then there's a sort of backwards and forwards and a bilateral set of negotiations about that. And then the member states come back with some plans and the EU issues recommendations. And the semester covers pretty much every policy area at national level. So unemployment, transport, energy to a lesser degree. I'm trying to think of a bunch of other ones, labour market, pensions, all of these things, but also health. And crucially, it is not written by, or at least in the beginning, was not written by and did not closely involve health actors. DG Sante were not involved in the initial iterations of the European semester. It began in 2011 and it's still running now. So we're into sort of cycle 12 at this stage. There was no health actor involvement. There was no health NGO involvement at the beginning. These recommendations were being written almost exclusively by DG ECFIN, the Economic and Financial Affairs Department in the Commission, with the assistance of ECOFIN, the Economic and Financial Configuration of the European Council, the Council of the EU. There was no involvement of health actors. And what was coming out were recommendations primarily about health systems expenditure, so the amount of money that governments spend on health, and pressures to reform the health system to do spending differently. And that's because health systems are expensive. Member states spend something on average between sort of 6 and 8% of GDP, 8 and 10% of GDP even, on their health systems. They are a huge expenditure item so far as economic actors are concerned. They cost a lot of money. And in the aftermath of the financial crisis, when everyone was trying to reduce the amount that they were spending, they were therefore an obvious target for the European semester process. So there were lots of calls to cut health expenditure, to reform health systems, and there was lots of pushback from health actors from within the Commission, but also outside the Commission and at national level, to say, well, hang on, we haven't been involved in any of those discussions, and what you're proposing is really damaging at a time when most member states were experiencing increased pressure on health systems because of austerity and people, huge increases in unemployment, which always leads to a decrease in health. Actually, the pressure upon health systems was getting higher, and yet the EU seemed to be recommending and pushing member states to reduce their spending. For some countries, and this refers to particularly Greece, but also all other countries that received either a bailout or some kind of financial support from the EU, the important point about the semester was that it wasn't voluntary for them. If you needed to receive money from the EU, you had to fulfill these conditions and these recommendations in order to receive the money that you needed. In Greece's case in particular, their memorandum of understanding, the agreement that they had with the EU and the IMF and the European Central Bank to receive the money they needed, it set a ceiling on their health expenditure of 6% of GDP. But of course, Greek GDP was collapsing at the time. So what that meant in real terms was changing almost day by day, and was forcing them to spend less and less and less on health at a time when Greek citizens were increasingly turning to their health system because of their state of living, their levels of unemployment and a sort of quality of life crisis at that stage. And this was hugely damaging, really hugely damaging. The same was true to a lesser extent for countries that had lesser financial reliance on the EU, but still some. This meant that these rules weren't voluntary in the way that they appeared to be from the way that they're written. Much has changed in the semester system, I would say, over the last 12 cycles. By 2015, certainly, there had been a real pushback from the health side, and health actors are now much more closely involved in the drafting of these recommendations. Member states are also much more conscious of the sort of horizontal impact of these recommendations and engage more closely in what's written there and what they mean. And of course, most countries are no longer in receipt of funding, so the extent to which they are binding has reduced a little, although I would point you to the literature on the way in which that strength remains in some cases, simply because of the specificity of what's being required, and the need to sort of comply or at least demonstrate some movement towards compliance with those recommendations. And that means that increasingly we do see recommendations related to things like access to healthcare, which is a positive thing, and the quality of healthcare. So you will see that the shift has come over the last 12 cycles from being focused very much on expenditure to being focused increasingly on access to care, universal healthcare, availability of care for minority or disadvantaged groups, for instance, and even the quality of care that's being delivered in some countries is now the focus of recommendations. Turning to the fourth phase, then the last phase of this sort of conceptualization of what EU health policy is, and this is quite new. If you turned to the let me think about the date, the 2014 version of the WHO volume that I showed the cartoon from, there is only lists 3 phases. The fourth phase was brought in the 2019 volume, and we have expanded it in the 2022 volume, and that's an indication of how the EU's interest in global health policy has grown over the last few years. So again, there is some mention, I think it's point 3 of Article 168, about the EU's interaction with third countries in the area of health, what we call third countries, so non-member states. And sort of building engagement and interaction with other countries and international organizations in the area of global health. And many of the areas that I mentioned in the 2 circles diagram about the different departments that have relevance for health, so the DG responsible for development, the DG responsible for trade, for research, for neighbourhood policy also, all of these are things, all of these are areas of activity that affect non-member states, right, that affect the health in states other than EU member states. So neighbourhood policy is a really good example, because that's all about helping member states prepare for membership, or at least in some instances it's about helping member states prepare for membership, and that quite often comes with a series of programs designed to align economic policy and labour markets and fiscal policy, and that all has a knock-on effect on investment in health and health infrastructure, for instance. The EU also has a role in international health organisations, so it speaks on behalf of member states at the World Health Organization, for instance, at the WHO. It's been played a leading role in the development of the pandemic treaty, which is currently under negotiation in the aftermath of COVID, just as an example. And in 2022, the EU came forward with a new global health strategy. So we had a global health communication in 2010, and that was accompanied by some conclusions from the Council about all the things that the EU was going to do in global health, and it simply got lost. It disappeared almost entirely from the agenda. Almost certainly that had to do with the economic crisis and the shift of attention. There were many other things going on, and it was just bad timing in a way. But we heard very little about global health on the EU side in between times. In 2022, we got a new strategy, and that has been adopted and sets quite an ambitious, or at least quite a wide-looking, optimistic sort of framework and recognition of the impact that the EU has at a global level, whether it means to or not. Because simply by virtue of being such a big trading actor, such a big market, such a big exporter, the EU automatically has an impact on health in other countries, whether it intends to or not. So the virtue of a strategy is to try and give some intention and direction and coherence, if you like, to that influence. We don't yet have council conclusions off the back of that strategy, and I mention that just as a slight reason for caution about how much commitment there is to this new interest or revived interest in global health. It doesn't seem to be being reflected at the moment in the Council in the EU as much as it is in the Commission. At the moment, the Commission seem quite enthusiastic about it, and the Council has yet to match that enthusiasm. So I just mentioned that as a slight caveat to a sense that there is a resurging interest in global health. I think that's true, but I think we have to be a little bit critical or maybe even skeptical about how widely that enthusiasm is shared. Okay, so I just want to turn to a little bit of integration theory, because I am hopeful that that might help to embed some of this in wider debates you're having as part of your courses. Health policy is an area that is really best explained using a neo-functional model. And I'll just mention a couple of reasons why that is. If we think about the gate in the middle of the field, health integration has happened around that gate. That gate represents a sort of absence of political will, and yet we've ended up with quite a lot of health integration anyway, and it's quite difficult to explain that using an intergovernmental basis, framework basis. It's much easier to explain that using a neo-functional set of tools. So in terms of the different kinds of spillover that neo-functionalism might point us towards, we definitely see functional spillover in areas like occupational health and safety, for instance. We have binding legislation in some cases in occupational health and safety because we have a free market for employees, for workers, because you can go and work in another member state. There was then a logical functional need to harmonise and equate some of the occupational health and safety laws. It couldn't be safer to work in one state than another if employees could move freely, if workers could move freely, because they would simply go to where it was safer. So that sort of functionally necessitated some harmonisation of occupational health and safety laws, just to give a really basic example. In terms of political spillover, the joint procurement of vaccines is a really good example here. There was no mandate for this. There was not even really in advance of it too much optimism, I would say, within the Commission that this would be an ongoing thing. So prior to COVID, the idea that joint procurement of medicines would be a regular feature was relatively mooted. This was pushed almost entirely by member states. It's member states seeking assistance and recognising the logic and the strength of cooperating at European level to procure vaccines, and then pushing for that cooperation to be formalised. That would give a really clear example of political spillover. Cultivated spillover, to me, is the much more interesting area of integration in health. So here we're talking about the idea that the EU itself and its institutions might be cultivating spillover, might be acting in an entrepreneurial or opportunistic way to bring spillover around and curate further integration. And here I can point to a couple of examples and a couple of sources. So the ECDC, which is the European Centre for Disease Prevention and Control, the expansion of their mandate has come very much off the back of COVID, particularly, as we'll talk about in a moment, but also other crises that have taken place before. That mandate expansion has been brought about by the ECDC taking on roles that aren't really within its mandate or competence, doing them well, and then finding a willingness to formalise those roles in the aftermath of that. They've done that very cleverly. And similarly, the role of the court, in a much earlier case, in the patient mobility legislation that I mentioned, that was brought on almost exclusively by the court. The member states did not want that legislation that allows you to go and take your healthcare in another member state because it's expensive for them. But the court ruled in favour of, in several cases, of patients who had received healthcare elsewhere and tried to get reimbursement in their home state. And the court ruled that was legal, and that was they interpreted the treaties to support a patient's right to take their healthcare elsewhere. So just two examples of where agencies and institutions have acted entrepreneurially to cultivate spillover, to push integration forward from the EU side. To me, this is the much more interesting area of health policy integration. You'll notice that I've mentioned crisis a little bit in that explanation, and crisis is a really important element of understanding health policy integration. Almost always integration has followed a crisis of some kind. So increasingly, a lot of you may be too young to remember, but the case of mad cow disease back in the late 1980s was about the infection of beef and problems with beef products, and lots of beef products having to be recalled, and that created a push to regulate food safety at the European level. Similarly, some of you will be familiar with the blood contamination scandal that affected many countries in the EU, but also across the world, where blood supplies were contaminated with HIV, and these supplies were given to patients who needed blood transfusions with disastrous and pretty horrific effects. Again, that was part of the rationale for starting regulation of blood safety at the European level. Thalidomide was a drug that was given to pregnant women in the 60s that turned out to cause deformities in babies when they were born. And that was taken off the market and found to have not been approved properly. And that was the push to create the European Medicines Agency and to regulate medicines at the European level. And we'll come on in a minute to COVID-19. The point with the crises is that again, our integration theory helps us to see how a lot of this is about pushing responsibility up level, to shift responsibility for areas, particularly of technical safety and quality, where governments don't want to take on the risk of being responsible for a crisis. So it's a good way of deflecting that responsibility, of pushing that responsibility up to the supranational instead. And we see that quite commonly across health policy integration. Moving to COVID-19 then, so I'm just going to walk quite quickly through the EU's response to COVID-19. The first thing to mention is the health programme, because the health programme was due to be not quite demolished, but subsumed within a much broader funding pot where it wasn't clear how much was going to be dedicated to health prior to COVID. Once COVID hit, the Commission completely reversed that, and it developed the EU for Health programme, and it then funded it to 10 times the amount. So the health programme now has a budget 10 times bigger than it ever had in the past. And that has all followed off the back of COVID-19 and the importance that was sort of assigned to the EU and the EU's role in health off the back of that emergency. And that gives us all of this action in areas of cross-border threats, obviously, because that's the category that COVID would fall under. So a lot of this is about managing threats to health that cross borders, but it also touches on medicines and health systems, and to some extent prevention of disease as well. So reaching beyond COVID to other areas. In terms of the strengthening of agencies and the creation of agencies, so I mentioned that the ECDC has seen its mandate expanded. The same is true for the EMA, the European Medicines Agency, which approves medicines. Both of those have had their mandates and the resources assigned to them expanded in the aftermath of COVID, because they started performing roles that they weren't performing before, and a decision has been made to expand to make that formalised and permanent. The HERA is the Health Emergency Response Authority, and it is in charge of pandemic preparedness. So it was created after COVID by the Commission to be a new body responsible for pandemic preparedness. So it will work with member states to develop preparedness plans, and it also has what they call an emergency sort of setting, where if another pandemic emerges, it will go into emergency mode. And HERA will be able to better support a response based on what we've learned during the COVID crisis. Civil protection is another area that we didn't used to discuss alongside health policy, but has now become quite an important part of it. So this programme called Rescue that I mentioned earlier was the main programme being used to respond to COVID in the beginning. But Rescue was designed as almost a matchmaking service. So Rescue was designed for example, if there were forest fires in one country, then other countries would send their aeroplanes that drop the water on the fires, or would send their firefighters or whatever was needed. The problem in COVID was that because everybody was facing the same crisis, the rescue program broke down, because no one was willing to send anything that they might need themselves very shortly. So Rescue has been expanded and overhauled in the aftermath of COVID, and in particular its provisions on stockpiling, which didn't used to include so much medicines and health materials, health resources, those have been changed completely. So we now have a much more comprehensive program of stockpiling things like PPE, protective equipment for health professionals, and all of the other things that would be required to set up field hospitals, for example, where they were needed. So we now think of civil protection as being quite an important part of the health policy machinery. Finally, the recovery and resilience funds. Now, this is probably the part of post-COVID that you're learning about the most, because it's the part that has the greatest implication for European integration across the board, I would say. The money that has been made available and the funds that have been made available for the recovery are being used to fund health system strengthening, to fund health infrastructure. So by that, I mean hospitals and care delivery services and things, because that money is being spent at the national level under the purview of member state governments. It's being used in the areas even where the EU doesn't have a particularly strong mandate in the area of health, but it's being used sort of in that way, and also more generally to strengthen health systems and health resilience. So it has a really important implication for health policy and how it develops, and also for health inequalities as well across and between member states. And that's an area that we need to really be paying attention to going forward. So I mentioned that this cartoon was put together for the 2019 version of the book. When we published the 2022 version of the book, a new cartoon was commissioned, and it looks like this. And what it shows, or is meant to signify, is the idea that what's happened since COVID has essentially completely blown away the gate that member states tried to build with the treaties. So member states had tried to keep the EU out of certain areas of the health system, for instance, but because of the amount of money that's now involved both in the EU for Health programme, this 10 times increase that I described, and in the recovery and resilience funds, which are channeling money into national health systems and the systems that surround them, that has essentially negated the purpose of the gate in the first place, that it's now almost impossible to say that the EU doesn't have a role in these areas that it's formally restricted from. So that's really the context in which I would encourage you to think about and understand the post-COVID situation for health, is that it has presented this opportunity to just get rid of the gate altogether and to almost irreversibly involve the EU in all of these different areas of health policy. Okay, so finally to turn to the health union itself then. So what is the health union? And it is, I think, quite a tricky thing in a way to get to understand and get our heads around, because it's not especially well defined. But I'll try to build it up so that you can see the kind of totality of what it might include. So when it was announced in November 2020, the health union was based on 4 initiatives. So this expansion of the ECDC in the EMA mandates that I mentioned, also the creation of the HERA authority that I mentioned, and we had some new legislation on cross-border health threats. So that was updating an existing directive that we had to really strengthen our response to essentially to pandemics, though some other things would fall under this description as well. But it was very narrow. It was these 4 pieces of legislation. It was very much focused on health security, on responding to what we'd learnt from the pandemic so far, really closely tied to sanitary crisis, to the idea of a disease that crosses borders that all of us need to respond to together. It wasn't anything more than that at the beginning, at least. Since it has been announced, it has become something of an umbrella, I would say, under which the Commission in particular is trying to gather a number of other things. So since it's been announced, a variety of other strategies have been described as being part of the European Health Union or contributing to the European Health Union. And all of this is about narratives, right? And about how the Commission describes a thing and therefore sort of builds what it is. But the narrative that has been used as time has passed is that the pharmaceutical strategy, for instance, which didn't initially have very much to do with COVID at all, the Beating Cancer Plan was adopted before COVID, that was already in place. So were plans for the European Health Data Space. The Global Health Strategy obviously followed, that was 2022, and the EU for Health programme was adopted around about the same time. All of these things are now being described as being part of the European Health Union. It's not quite clear how or why, but when the European Commission discusses them or presents them, it will say, and this is our Beating Cancer Plan, which is part of the European Health Union, despite having been adopted before the Health Union was ever mentioned. And I think what we have to understand from this is an effort on the part of the Commission to build the Health Union into something bigger and stronger and more significant. And I'm moving a little bit further forward in time, I would add another layer to this, which is to say that things that were already in place long before COVID are now also being described as part of the Health Union. So here I would include renewed policy on the substances of human origin, so blood, tissues and organs. Some of that has been in place since the early 70s, mid 70s maybe. Legislation on clinical trials has been around for decades. The State of Health programme was put in place long before COVID hit. But if you look now, even just to the website of the Commission, these things are now described as being part of the European Health Union. What that means going forward, is it possible that new policies, priorities and ambitions might be included under the Health Union? I've just put some examples down here. So the EU, in theory, has a commitment to universal health coverage, to everyone being able to access care within their home countries. It's possible that that could be built to be part of the European Health Union. Its work on health inequalities, again, very soft, not based on any regulation or any hard law of any kind. We could build that into the Health Union. Climate change is increasingly being discussed as an activity. Sorry, by that I mean the work on the relationship between climate change and health is being discussed as an activity that might be part of the Health Union. Antimicrobial resistance, which is one of the most pressing and important areas of health policy that the EU has at the moment, also being discussed under the umbrella of the Health Union. At the moment, there is no indication that the semester or the fiscal governance framework are thought of as part of the Health Union, but that framing would provide an interesting tool for reorienting what it is we think the semester is for and what it should be trying to achieve. Similarly, work that's coming up on ageing populations and health systems. Towards the end of this, the question we need to ask is whether it's possible then, if we were to include all of these kinds of areas, for the Health Union to reach really beyond resilience. So beyond resilience against sanitary crisis, beyond simply being about health security and communicable diseases and threats that cross borders. Can it be about something else? Can it link into our idea of a European social union? How does it interact with our idea of the social model and perceptions of solidarity and contributing to perceptions of solidarity? These things could be linked. They haven't been yet. I'm just throwing out ideas for how the Health Union could evolve and might be used. And these are links that could perhaps be made. There was discussion of a strengthened legal basis at the beginning of COVID. You might remember I think it was May 2020, Angela Merkel and Emmanuel Macron were talking together about the idea of opening the treaties. Angela Merkel, in fact, said she was open to the idea of adjusting the treaties to strengthen the EU's powers in health. That never came to anything, although it was a big statement at the time. But it was indicative of a political recognition of the importance of EU health policy, and there remains the possibility that would be an avenue forward in the future. The role that the Health Union would play within that, I think, would be interesting. So in terms of talking about what the Health Union is, I think my suggestion would be that we can understand it in two ways. To one extent, the Commission is looking backwards and it's using the Health Union as an umbrella for things that it was already doing. And the reason it's doing that is because there is a real sort of absence of coherent objective to EU health policy. There isn't something that all EU health policy, is geared towards trying to achieve. It's quite a disparate policy area where there are lots of different activities and they're mostly about trying to improve health, but there isn't a single central goal like the creation of an internal market, for instance. So to some extent, the value of the Health Union is for the Commission to try, or DG Santé to try to gather what it does under a single umbrella that gives it a sense of coherence that perhaps it lacked before. I think the other way of looking at it is forward-looking, is to think about the Health Union as an opportunity for framing future actions, for framing things as part of this coherent entity that the EU is trying to build in a way. So in that sense, it's a sort of framing tool, but for future actions and for new ideas that the EU might want to engage in the area of health. I just wanted to quickly show this slide, which is from a study that we conducted using complexity theory, and we used it quite loosely, but we've used it to demonstrate, and I think it's graphically quite helpful as an illustration of how the EU's role in health has changed over time. So we mapped essentially all of the policy activities that the EU is engaged in health from the late 90s right the way through, early 90s, sorry, right the way through until 2020, essentially to show the change in the kind of policy making that the EU engages in health. So much earlier on, you can see that the policy making was much more in zones 1 and 2, so techno-rational and political decision making, which is as it sounds, it's much more in areas where we have certainty about what the solution is. So for instance, in the regulation of medicines, you know, there's a degree of certainty about what a good safety system would look like for medicines. There is a way of solving that problem and then adopting the relevant legislation. Just as an example, that the kind of policy the EU was engaged in then, during those time periods, had a much higher degree of agreement between member states and between experts knowledgeable in the policy areas, and certainty about what the good or the best solution was. As we move to 2020 and indeed past 2020 to the sort of post-COVID period, you can see that we're moving up the axes in both directions. So not only are we much less certain about the different policies that the EU is seeking to engage in, the answers are much less clear, they're much more contested. We also have much less agreement about what the best way forward is. That we're talking about policies where culturally or in different member states, for instance, the approach might be very different, and it will be harder to get agreement on what we should do going forward. I'm dramatically simplifying an entire paper's worth of work here, but it's just to try and show you visually how the nature of EU health policy has changed over time and what that means for the politics of the decision making that the EU is currently engaged in. Some quick conclusions then for the future of EU health policy, maybe just as a sort of food for thought for some discussion. To start with, what health policy right now is not in 2023, it is not grounded in a stronger legal basis. So we talk a lot about the integration of health after COVID, and that's true, but it's worth bearing in mind that there isn't a stronger legal basis. There's no stronger mandate. We haven't changed the treaties. So the mandate that I described right at the beginning in Article 168, that is still the same. Nothing there has changed. It is perhaps improving, but it is still not very closely related to ideas of solidarity or risk sharing or redistribution, which particularly if you've been studying EU social policy, we know are important to creating integration and indeed any area of sense of union or social model. In these senses, the EU has no greater powers of redistribution. There's no greater sense of sharing risk across member states in these areas, and indeed what solidarity means in this context remains unclear. Perhaps most importantly, these changes that I've described are mostly not permanent. The health union is an idea. It's an entity that is being described on a regular basis by the Commission, but it doesn't have any legal mandate attached to it. There's not really any resource attached to it. The EU for Health programme, yes, the budget is 10 times the size and there are many more things happening, but everything that has changed post-COVID is reversible. And that's the important point, and perhaps the concerning point if you're an advocate of a greater EU role in health for where we are right now. All of these things could be very easily undone or allowed to fade away and disappear under a new Commission leadership, for instance. Once the political machinery changes, it's completely possible that most of these things will disappear. None of it has been made permanent in that sense, and we need to be mindful of that. What health policy is in 2023 is more political and less certain than before, as I demonstrated on the previous slide. a lot of the policy areas being addressed now are more sensitive, involvement in health systems, strengthening, for instance, oversight of shortages of medicines, which is coming up soon. These things are really political and sensitive. And also many of the issues being addressed are less certain, that they're less clear. We have less of a consensus within the research about what we should be doing about these problems, and that's going to lend itself to a very particular type of decision making. However, they are all based on quite a strong statement of commitment from the European Commission and a greater or lesser degree of consent from the member states. And as we've talked about, really enhanced resources for the EU's role. I would also say that we're still operating very much on this traditional model of integration via crisis and spillover. We can see already in 2023 that some of the interest in these areas like global health that was pushing ahead in a crisis situation, some of the interest is starting to wane now that the sense of crisis is perhaps passing. So I wouldn't say there has been a dramatic shift in the model of integration that we see in health. And finally, in terms of what a health union is, it is a union, and that use of the term union is significant. If we think about the banking union or the energy union within the EU, the term union is used in a very specific way, and it is significant that they've chosen this term for health. I think that indicates a degree of commitment that we should be quite optimistic about. But as I mentioned, the focus formally on health security and sanitary crisis is perhaps a cause for concern. It's a cause for concern if what the health union means is simply a union to address pandemics and not to address all of the underlying causes of poor health within populations and of inequalities in health between member states and within our member states. If we were being critical, we could say it's primarily symbolic and political. So Ursula von der Leyen stands up and mentions it at her State of the Union speech, but then nothing too much happens in between at that high political level. Perhaps we could view it as a symbolic and a political entity. It is potentially legitimating. It does perhaps legitimate the EU's role in health if we can bring all of those actions under the umbrella that I've described. It perhaps offers an element of legitimacy and direction to what it is that the EU is trying to do. And I think if we were going to be at the most optimistic we could be, we could say that it's a space for what I would call proofs of concept. So the idea that we can try things under a health union and see how they work, where they might be beneficial and where they might be not, and that those ideas might be influential. If it lends that legitimacy to the EU doing a little more in health under the banner of the health union, then it might work out to be something quite positive going forward. But I think that remains unclear and perhaps to be seen at this juncture. Okay, I'll leave it there. Thanks so much for your attention and for the invitation and the opportunity, and I look forward to answering any questions anyone has and engaging in some discussion.
Thank you very much, Eleanor, for the very comprehensive explanation on the European Health Union. Yeah, we can open now the floor for if anyone has any question, any comment. Now is the moment. Opinions. I mean, I had a small comment, a small reflection. I mean, I remember during the pandemic that the expectations for centralization in a way of health policy in the EU were probably, my impression is that they were much bigger than the final European Health Union project. So, I mean, I don't know if you agree with that at the end, this project has been a little bit more limited than it was expected at that moment. And if this is the case, why do you think that this has been the case? What have been the main obstacles towards a greater centralization or greater integration in the domain? I don't know, maybe we can collect some other questions. Anyone has a question or a comment? Okay, for the moment, this, Eleanor.
Sure, yeah. I don't think that's an inaccurate or an unfair description of what's happened. As I mentioned, that moment in May 2020, I think it was, when Angela Merkel and Emmanuel Macron were committing to or expressing openness to changing the treaties to strengthen the EU's power in health. That was a huge moment, completely unthinkable prior to the pandemic, frankly, that we would have ended up with a stronger legal basis from health. That nobody would have anticipated that. And it's passed, and we got no stronger legal basis. So on that basis, I think what you're describing is accurate. In terms of barriers to why it happened, I mean, I think the crisis literature is useful to us here. You know, crisis produces a certain set of responses. It produces a degree of a sense of solidarity, perhaps, and enthusiasm about cooperation that doesn't exist outside of a crisis setting. It causes decision making to be done differently and people to shift their perceptions of things during those time periods. Once the crisis passes, then things tend to shift back, I suppose, is the simplest way of looking at it. I think in terms of how much has changed, like some of that is about the difficulty of expressing the rainbow model to policymakers, essentially, of helping. So a lot of COVID, particularly for the public health community, I suppose, was about trying to help policymakers understand that, yes, okay, the immediate problem is because of this particular pathogen, this disease that is circulating, but actually the impacts of it, the patterns of where we saw mortality, for instance, which affected disadvantaged groups much more so than advantaged groups, that's all about underlying aspects of public health that we've not been dealing with sufficiently for decades, right? If our public health systems were stronger, if we did more to address the impacts of poverty and unemployment and education and working conditions on people's health, then the outcomes of or the effects of the pandemic would have been very different. Now, that to a public health scholar or professional is a given, it's completely obvious, but conveying that in a political setting in order to harness the increased enthusiasm, if you like, or attention of policymakers, and then translating that to a change in the EU's powers in health is really difficult. It's very difficult to make that case and to see the necessary power increased at the EU level on the basis of that argument. That's very difficult to convey. So I guess we could think of what you're describing of the sort of failure of the health union to live up to perhaps the expectations that were set out in mid-2020 as an example of, or a demonstration of, the difficulty of implementing this idea of health in all policies, of the social determinants of health, and the need to tackle health across every policy area, and not just to devise a health union for health security and sanitary crises, which is in reality what we've sort of ended up with. I see it all in terms of that battle to create health structures at the EU level that take into account what we learn from the rainbow model. And historically, we've never done that well, and I don't think it's come out too much different off the back of the pandemic. There are some parts of the health union that are focused towards improving health systems more generally, you know, strengthening primary care and all of these good things, working on prevention of disease rather than just treating disease, but it's still fairly minor. And that is the big hurdle that we are still waiting to jump at national level as well, but also at the EU level.
Yep, thanks. Okay, any other comment or question? So then we will leave it here, Eleanor. Eleanor, thank you very much for your attention, and sorry for the camera. We haven't been able to solve it, but well, technicalities. Thank you very much.
All right, no problem. Thank you very much for the invitation.